So thank you all so much for joining us this evening for tonight's Radiotherapy UK Talks, Sexual Wellbeing and Cancer, sponsored by AstraZeneca. A really warm welcome to you all. Although this is a series built for the workforce, we very much welcome any patients who have joined us tonight. Last year's talks were all about new development and innovation, and they were immensely popular and are still available to view on our website. And this year, thanks to your feedback, our theme is enhancing the patient experience. So I'm Sarah. I'm the director with Radiotherapy UK, and we are the only charity in the country advocating specifically for this life-saving, cost-effective curative treatment, the patients that receive it and the workforce that delivers it. So with your support and through our award-winning Catch Up with Cancer campaign, we're here to create change at the highest level. And I have two updates for you tonight after our presentations. So quickly, I'm joined tonight by Lindsay and Sarah from our team who will help run the session. Lindsay worked as a therapeutic radiographer for many years and will be helping out with the questions section later this evening, and Sarah will be looking after the chat. Tonight's guest speakers will be tackling sexual well-being and cancer from different perspectives. Holly Masters was diagnosed with cancer at the age of 23 and has gone on to become a successful actor and a really committed patient advocate. Also, can we just say a huge congratulations, Holly, who's just found out this week that she has been selected as one of only 18 young people to join the National Youth Theatre 2024 rep company. So seriously, well done, Holly. That is totally amazing. Then we'll hear from Dr. Lisa Ashmore, who you may know for her brilliant work on the gynae narratives. Dr. Ashmore is a clinical therapeutic radiographer, researcher, and senior lecturer. And then last but not least, we'll be joined by Lorraine Grover, who is a psychosexual nurse therapist and sex therapist. So please do use the chat function to introduce yourself and for any comments and questions. This is such a good opportunity to engage with each other and with our speakers. And we will have a question and answer section following all three speakers. We'd also really appreciate it if you could comment in the chat with your main takeaway after each guest. So without any further delay, please welcome Holly Masters.
Thank you, Sarah, and thank you very much for your kind words about the rep company. I'm very excited. It's great to be here this evening, and it's great to see so many of you here as well, wanting to make a difference to patients. For a bit of background, I was diagnosed with rectal cancer back in September of 2021 when I was 23 years old. And amongst other treatment, I had chemoradiation for 5 weeks just before the end of that year. So the first thing I want to say is that sexual well-being during cancer treatment is important for everyone. Regardless of anyone's age or background, it's crucial that we don't make any assumptions about people's needs, including not making assumptions about their sexual orientation. We know sadly that LGBTQ+ people often face even more barriers when it comes to help around sex and intimacy. But I want to stress, particularly as the radiotherapy workforce, that no one, including patients, is expecting you to have detailed knowledge of everything around sexual well-being and what someone might need, because that's very individual. But what we do expect is compassion, understanding, and acknowledgement that this is an important thing for patients, as it's an important thing for us all. You don't stop being a human with desires just because you have cancer. Crucially, what we need is for you to be able to signpost to the appropriate support if you're not able to give it. So what are the effects of cancer treatment on patients' sexual well-being? Well, firstly, I think a lot of patients feel that they have a lack of knowledge about what might be safe, and this sadly can stop them from pursuing a full sex life. And what is safe will be different for everyone, depending on their cancer and how that impacts them physically, and also the treatment that they're having. But not knowing what's okay can mean patients are overcautious. There are some things that will apply to everyone. For instance, on chemotherapy, we know that certain precautions have to be taken. I remember being sat having my chemo and a nurse asked me if I had a partner. When I said yes, she told me to use protection for a few days because it can be passed through bodily fluids. But that's all she said. And it left me wondering afterwards what exactly she meant, as I don't think she was really specific enough. Did this mean sweat and saliva? Like, how long is a few days? And the problem is, healthcare professionals can be uncomfortable talking about it. So oftentimes they're not specific. But in my opinion, that's incredibly negligent. We need to make sure we're being specific enough in order to keep patients safe. It's really important. And that goes for partners too. They need to feel safe and supported as well. I think often partners get forgotten about amongst everything, but ultimately our sexual well-being will impact them as well. And I want to stress that whether or not someone has a partner, their sexual well-being is still important to them and needs to be discussed. People may also have significant changes to their body as a result of their cancer and treatment. This could be a whole number of things, but could include things like losing a breast or having surgical scars or living with a stoma. And all of these things have the potential to affect someone's confidence and the way that they feel about their body, which may then also have an effect on their sexual well-being. We sadly know as well that cancer treatment can have a huge effect on sexual function, which I won't go into detail about, as I'm sure our other speakers will probably touch on this, but physical changes to people's sexual organs will of course have a huge impact on their sexual well-being, which will in turn impact their mental health. And these changes can happen after treatment too. Late effects can happen anywhere from 6 months to decades later. And as patients, we need to be aware about potential effects that could happen. And as clinicians, you need to be able to get us the support that we need whenever we need it. So how do we address sexual health and intimacy with patients effectively? Well, firstly, we need to break the stigmas and create environments where patients can talk about it. Ideally, we need to start talking about it as soon as possible after diagnosis. In my opinion, it's everyone's collective responsibility to bring this up with patients, to check in on them and provide support. And in order to minimise potential long-term issues, it's got to be at the forefront of clinicians' minds. So be thinking about as opportunities as radiographers that you could bring this up with the patient. If you're sitting down to discuss the treatment and side effects before they start, can you also ask what support they need around their sexual well-being, for example? I guarantee you they will be worrying about it. So if you bring it up, that gives them the permission to talk about it and an opportunity for you to understand their needs and offer support. Sadly, in my experience, it was something that I had to bring up myself. There were a couple of occasions where I tried to advocate for myself and didn't feel supported. The most disappointing example of this was during my radiotherapy treatment. I remember speaking to a therapeutic radiographer in the treatment room and asking what I could do during the treatment to help reduce some of the late effects. And all she said was, "Oh, don't worry, you won't want to have sex." And I look back now and I've got to be honest, I'm quite angry that that was the response that I got. She just totally dismissed my concerns and also made assumptions without knowing anything about me. And I understand that, with certain treatment, there will be common side effects that might make sex more difficult, but it's going to affect everybody differently. We know patients, they have all different types of side effects, and not everyone has everything. And we need to be giving tailored support when patients reach out for it. It's also important to remember that although you will see patients every day, the experience for people affected by cancer is very different. It's all completely new and scary to us. So don't lose sight of how big of a deal this is to each individual person. So what would have helped me? I think it's quite clear that I shouldn't have had my concerns dismissed. I should have also been able to talk about what was worrying me and been able to have a conversation about my personal circumstances. I should have been signposted to information and support about what's safe, and there should have been consideration of sexual well-being throughout the pathway. Things should have happened automatically without me having to advocate for myself. So I wanted to finish with 3 top tips that you can take away. Number 1 is don't make any assumptions about sexuality or sexual well-being. It's important to everyone and must be tailored for the individual. 2, if you aren't able to give specific advice, make sure you have the knowledge to signpost to services that can. 3, and most importantly, remember that we're people first and patients second. It is so important as patients that we don't lose ourselves when we have cancer. So let's empower people with the knowledge and the tools to take care of their sexual well-being. Thank you very much.
Thank you so much, Holly. That it's just really powerful to hear from you speaking about that from your own personal experience. And thank you so much for sharing that with us. And for the tips for the workforce as well. You know, some really practical advice there that can be taken away. So thank you so much for that. That was really, really remarkable. I'm going to move on now to Dr. Lisa Ashmore. And Lisa, if you want to bring up your slides there. There we go.
Right. Oh, wow. I don't know whether it's worth even trying to follow that, Holly. I think that you've just left us with the strongest point, and I feel like I am now going to ruin everything by talking for the next 15 minutes. But bear with me and try and remember some of the stuff that Holly talked about, because I think it resonates with some of what I'm going to say. So my name is Lisa Ashmore. I'm a senior lecturer in social sciences at Lancaster University Medical School. I'm also a clinical academic therapeutic radiographer based at the Rosemere Cancer Centre in Preston. So I want to prompt you in this next 10-15 minutes to think about how sexual wellness and pleasure is a human right, part of our rights as individuals, as humans, and think about how, as healthcare professionals, we have a responsibility to address the impacts of ill health on sexual wellness at all stages of the treatment journey. So the work that I've done, as Sarah mentioned when she introduced me, was originally working with gynae cancer patients. So mostly I'm thinking in that context, and all of the people that we worked with identified as women and identified as heterosexual. So that's also important to remember with some of the work that we present with the Gynae Narratives Project. But actually, we've tried to pull out a lot of the work that we think relates to more generally. So from the Gynae Cancer Narratives Project, let me move my slides along. Okay. We collected people's experiences of their treatment, and quite a strong thread that came through that were people's experiences of their sexual self during and after treatment. And this quote by Donna really kind of pulls on what Holly was saying. I think that it's very hard sometimes that people don't acknowledge sexual selves for patients. And Donna says, the effect of losing my cervix is that I have never been able to resume full vaginal intercourse. And that's been very hard and pretty much unacknowledged by oncology the whole time I was attending. And there were quotes like this throughout the Gynae Narratives Project, and I've put some of them up here. I've presented this before, so some of you might have heard these before, but people talked about owning their body, feeling attractive and having choice. Some people described having a loss of self-confidence or feeling unsexy. Some people didn't feel like their bodies belonged to them, or they felt like an old bag. People described wanting to have a sexual self, with some feeling guilty for this when they should be concentrating on the cancer. And we certainly heard that story many a time of people trying to bring this up with healthcare professionals and it being minimised or being told that this is not something for you to worry about just yet. So the only longitudinal study on patients' experiences of sexual well-being after radiotherapy was published in 2013, and they measured function in terms of sexual interest, lubrication, painful sex, vaginal dimension, and the ability to complete intercourse and satisfaction with a sex life. And this study found that persistent, what they termed sexual dysfunction and adverse vaginal changes were reported throughout the 2-year study period. When we're looking at sexual well-being, studies rarely, if at all, ever address issues of sexual wellness and of pleasure in these kind of non-pathologized or medicalized terms. So when the focus of sexual wellness and pleasure is considered in terms of sexual function, recognition of any effects of treatment beyond those that affect predefined notions of function, typically penis and vagina penetration, there is a tendency to medicalize or silence experience, or actually introduce feelings of blame for individuals. So if we don't acknowledge the harms of treatment or the lived impacts of the intervention, it actually denies somebody the opportunity to talk about their sexual health. And I think a lot of the time we silence parts of the conversation because we don't have a pathway for referral. So when somebody says to us, what can I do about this? Or I'm feeling this, actually, we want to, as healthcare professionals, we often want to fix it, or we want to send someone somewhere else where it can be fixed. But often people just want to say, actually, this is just a bit shit for me right now. And they want the person in front of them to nod, acknowledge, and not feel embarrassed or blush or move them on to a different topic. So these biomedical approaches can be considered to dissect and pathologise sexual human lives, and it cuts people into body parts, treatment pathways, we silence experience, and we also silo healthcare information. So this focus on the dysfunction or function fundamentally takes what's called a deficit model approach to sexual well-being. And that focuses on this kind of what's missing. And we kind of think about things about sexual abuse, sexual violence, unintended pregnancy, sexually transmitted infections, dysfunction. So those are all parts of the deficit model. But actually, if we took a kind of human rights or more holistic view to sexual well-being, we would think about sexual agency and sexual health. We would think about sexual attraction, sexual identity. And actually, this aligns with the World Health Organization's definition of sexual health. So the quote that I shared earlier from Donna, she goes on to say, when I mentioned visiting a sex shop at my next checkup, they, which is referring to the oncology team, looked rather embarrassed. It was then I really understood that it's no good asking a nurse or a doctor, and I've added in radiographer, at a cancer clinic to give advice beyond their area of expertise. It wasn't fair on them. And I think we're in a really sad place when we've got patients who are protecting the healthcare professionals from having awkward conversations, which would help them with their own well-being. I referred to the World Health Organization definition of sexual health, and they say it's a state of physical, emotional, mental, and social well-being in relation to sexuality. So it's not merely the absence of disease, it's not dysfunction or infirmity. Sexual health requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences, free of coercion, discrimination, and violence. For sexual health to be attained and maintained, the sexual rights of all persons must be respected, protected, and fulfilled. And I'll go on to talk about those sexual rights later. And I want us to think about, as healthcare professionals, how do we respect, protect, and fulfill, or help people fulfill their sexual well-being and their sexual health. Department of Health, if we're looking for more definitions, they also define sexual health in a more holistic way, thinking more about mental health. They don't pull on as much of the social aspect as the World Health Organization, but they do say it's a key part of our identity as human beings, together with fundamental human rights to privacy and a family life and living free of discrimination. Equitable relationships, sexual fulfillment, with access to information and services to avoid the risk of unintended pregnancy, illness, or disease. So actually, are we providing people with the information that they need and the services that they need to actually have a fulfilled sexual health after radiotherapy or during radiotherapy? So this isn't actually a new thing to start thinking about sexual health in terms of disability in particular. So Anne Finger is a polio survivor. She's an activist for the disabled, and she wrote quite a lot about her own disability. And she says, for disabled people, sexuality is often the source of deepest depression. It's also the source of deepest pain. It's easier for us to talk about and formulate strategies for changing discrimination in employment, education, and housing than to talk about our exclusion from sexuality and reproduction. So she's thinking about the disabled body of people who experience disability. But actually, if we think about this for cancer patients, people living with cancer, people living after their diagnosis, we think actually we do talk about employment, getting back to work after cancer. We do talk about people having income. We talk about all of those things, but do we talk properly and fully about people's sexual health? So I said I'd talk about sexual rights. So the World Health Organization have various rights in relation to sexual health. And I've highlighted some of the ones here that I think relate to some of the things that we found in the Gynae Narratives project. So some of these are actually, you know, fundamental across all of cancer care, but the ones that we really found in the Gynae Narratives project were people talking about degrading treatment, potentially having to walk across treatment rooms unclothed, people being left uncovered on the bed, a right to privacy, the right to the highest attainable standard of health, including sexual health. So actually, when we dismiss that as sexual health as not being important for patients, are we helping them? Are we fulfilling their right to the highest attainable standard of health, sexual health? Also, the rights to information as well as information. So if we aren't doing this, we are actually denying people their rights. So we worked with, following the Gynae Narratives project, we worked with an organisation called Me and Her, who really helped us think about this rights-based approach to sexual health. And if we think about sexual health as about being about well-being, not about being about function, not dysfunction. And well-being could be about pleasure or having a meaningful life or flourishing. Sexual well-being relates to how people experience their lives, specifically their sexual selves and their human relationships. So Holly mentioned about having a partner, and often we think when we're talking to people about sexual health, we often talk about partners and we say, oh, is it affecting your relationship with your partner? But actually it's about your relationship with yourself and how you see yourself. And there are so many different relationships that people might be having that we can't just minimize it down to actually what we're talking about there is, are you able to have sexual intercourse or those kind of physical relationships. So well-being is not only the absence of problems or the presence of happiness, but it concerns somebody's experience of being able to like self-actualize, to be their best them, if we want a better word, social integration, its mind, its body, and its environment. Okay, so I said that we joined together with an organisation called Me and Her, and we were funded by the European Economic and Social Research Council, sorry, not European. And what we wanted to do was really address that quote by Donna where she said it's not fair on asking practitioners about this stuff, because actually we think it is fair, but we also know that it's difficult for one practitioner to do that on their own. So we wanted to come together to help practitioners improve their confidence, to share best practice, and to own their embarrassment and knowledge or lack of, and advocate for a culture shift in how we prioritise sexual wellness as a part of care. And I'm really pleased that actually some of the people who joined us on this journey are in the audience today. So thank you for joining us. Okay. So we did 3 online workshops. They ran from May to June in 2022. We did introductions, we did definitions, we talked about language, we talked about sex, we opened ourselves up to critique. We did this very fun, hopefully, and engaging set of activities. We then had a 4th workshop, which was in person, where we decided actually we wanted to co-design some materials which would help have conversations about sexual well-being that we could then share with other people who hadn't been able to attend the workshops. So we had a designer who came and helped us design some things because we decided we weren't very artistic on our own. And then we had a 5th workshop with patient representatives and the team where we kind of talked through those materials. So what did we make? We made this set of cards, which seems kind of, I don't know, it feels a bit basic really somehow, but we decided that you need a conversation starter. If we're going to do these things, we need something that you can maybe use to initiate a conversation. So you'll see that there are word clouds there that people, you could say, how do you want to refer to your genitals? When you're thinking about dilators, what do you think about? Do you want to explain more of that? So these fit in a plastic wallet that go on a lanyard, and they're just conversation starters. We call them practitioner cards. As I mentioned, we were focusing very much on support for gynae cancers, so you notice that in the pictures. We put some of those together in a poster, which isn't very appealing, and the poster is my least favourite part of that, so I'll skip on for that. And we also created a set of playing cards. So these were designed with multiple audiences in mind, and the hope is that they might help people have conversations with a loved one, a clinician or a patient. And they're a bit more mixed, and they include some of the same cards as the practitioner ones, but also some more details about the Gynae Narratives Project. So some quotes that might help people have conversations. I am a researcher. This is fundamentally a research project. So we're not claiming that this is, you're going to, solve care, be implemented in care. But what we want to do is we want to push people to start having more conversations about sexual well-being, and to really think about how can we do that rights-based approach to sexual health. All of the materials are available for free from the Lancaster University website. You can get those by scanning the QR code. This was a team effort, so the Gynae Narratives Project was funded by Northwest Cancer Research in collaboration with Lancaster Cancer Centre. We had various other people who were involved in bits of the project, so I don't want to ever claim that this is all my work, because it is definitely the work of the team. And I'm going to stop there. Thank you very much.
Thank you so much, Lisa. I'm a big fan of the Gynae Narratives Project. I think it's fantastic work. Again, it's quite groundbreaking, bringing patients right into the heart of the discussion, sharing their thoughts and their words, and then practically thinking about what can change in the front line for people to address these issues. Just thinking there about the WHO definition of sexual health, the physical, emotional, mental, and social well-being, it's the entire package that we're talking about here. And I just think that's really powerful, and it's really fantastic work. And I'm sure that Lorraine has a lot to follow on from that. So if I could now introduce Lorraine Grover.
Can you hear me now? Thank you for the invitation. I'm so excited, really excited. What's so interesting is the overlap from hearing what we've been hearing tonight. And one thing that absolutely thrills me is I no longer feel I'm the one in the MDT 30 years ago saying, what's happening about the patient? Are they in a relationship? Are they not? And everyone look at me like I was some idiot. So it's fabulous to think that things hopefully will change. And whenever I hear the patient talk, and when I heard Holly say what she said, I got goosebumps, and I find it really upsetting. But we're all on a mission here to change things. So I like my light bulbs. I do like being visual. And there's a light bulb moment. So some of you may already be discussing sex, and some of you may not be. But hopefully this will encourage you all to do so. And if you're a patient on here, that you will take that step and ask for some advice. I do specialise, I've specialised in prostate cancer for a long, long time. But I always talk with a partner as well. So actually, I've learnt more, and I've gained my confidence talking to same-sex couples or heterosexual or female partners as time's gone on. So just take that step. It will absolutely transform a patient's life and maybe their partners. And it will change your career if you start to talk about sex. So, now I can't get my slides to move on here, which is, I checked that my screen would. Aha, here we go. There we go. So we've been hearing about education, healthcare professionals, where whoever you are watching, listening to this, initiating the discussion, people want more information to feel comfortable to do it. And I started this doing Viagra trials back in the 90s. And I was so embarrassed when I was given out these pot of tablets and the patients were talking to me about their sex lives. I didn't know where to look. I was tongue-tied and it felt really awkward. So I know what it feels like to be on that side of the fence. So the knowledge relieves your anxiety and it makes it better for patients. And prehabilitation is quite a buzzword, isn't it, in cancer care? And people talk about being fit for surgery and fit for treatment. And I would say it's the same for sexual well-being. Let's address things. And we've heard that early on, right at the very beginning, that we raise awareness about patients' sexual well-being and we normalise that discussion, because we have to be able to provide bespoke, individualised care. So as well as the World Health Organization, World Sexual Health Day falls September the 4th every year. And I loved it in 22 when it was Let's Talk Pleasure. And pleasure is what sexual well-being is all about, whether you're on your own or you're in a relationship or in multiple relationships. And as we've been hearing said, do not assume that that person sat in front of you, or yourself as a patient, that the clinician that you're speaking to is who they are. We have no idea. So you want to be curious and you want to get rid of any assumptions, and whatever age the patient is, that you will be addressing their sexual well-being. And again, it's about this human right relating to sexuality and sexual well-being. And it's relevant through a person's life, through to adolescence and into older age, and not just the reproductive years. So communication is really important. And think about what's in your clinical room that will aid the discussion. So I've got here behind me on the shelf, I have a rainbow. When I do Zoom appointments, I've got a rainbow. And it's really important. How can I provide bespoke, individualised care? So think about clinical rooms, the office. Think about if you go into a clinic, is there something there that clinicians got that's going to trigger and feel comfortable for you to talk about sex? And think about the language. I often say to patients, what do they call your penis? Dick, John Thomas? You tell me. I've had Benjamin, I've had all sorts. What I didn't realise was the emoji for a penis is an aubergine. So when I got asked to write this for Look Fantastic, it came back to proofread with that aubergine on, and I went, what on earth is that all about? And then found out. So that when we talk to patients, or you're going to express about having an orgasm or being able to ejaculate, sometimes I'll get slang words mentioned to me that I may not understand what they really mean. And I will just say, what do you mean by that? I have to say, Holly, you're a lot younger than me, and I imagine some of the language that you've got about sex, I might not understand, or dating might be different. So I never hesitate to own up and just say, tell me a bit more. I'm being curious. So if you're not sure about something, just ask. Do we provide lip service to patients? I would say we do a lot of the time. That embarrassment, which we've heard mentioned and in the studies, we need to be able to move on with the information that we're given, not just file it into notes or do a tick box on a computer. You can see here lip service. I've got a little bit here actually. The red lips, I quite like the ornaments, that's on my dressing table. And in the middle, we can see a lipstick. Well, is it a lipstick? Well, I've got two here actually, a lipstick, but the middle one is the same as this one, and it's a vibrator. So when I heard the talking about sex shops and the embarrassment, I actually encourage people to go to sex shops. I encouraged someone today actually to nip down Oxford Street. I'm based in London, and there's a sex shop, because actually I won't know what type of sex toy the patient might enjoy. I can talk about them, but I want them to hold them, feel them, and get to understand what they might like, what turns them off. So I can open up the dialogue, but I don't know the finer intricacies. You could use questionnaires. So you could get your patients to fill these in before they attend. You could do it part of your radiotherapy assessment. So the Female Sexual Function Index is one questionnaire. We've got the International Index of Erectile Function. I love this because it tells me more than just about the penis. It'll tell me about orgasm, arousal, desire, satisfaction. And there are several things that are involved in a positive sexual experience. So questionnaires, if they get sent out and completed, actually look at them and action on the information. And I expect a lot of you might be thinking, oh, we haven't really got time in the clinic. Don't let that be an excuse, because you can start that conversation and you can carry on that conversation throughout the patient's clinical appointments. And assessing sexual function, I think having tools around makes it really easy, if you don't mind the pun. The medical history, you may know that, but you may not know the sexual history. So I often say to patients, tell me a bit about your sexual life at the moment. Are you in a relationship or not? It's really important we help address this with you, because we know the impact, you might be all here from different disease areas, has on a patient's sexual well-being, and that may impact on their relationship too. And we're here for you all, because that actually is that olive branch to get this discussion happening. The hardness score is quite good, because if the patient says, well, I'm 50% there, what does that really mean? But if they say, I'm grade 2, hard, but not hard enough penetration, that gives you some information that you can audit and write down. I've got a velvet vulva here, so I've got this on my desk, and that will actually help people to talk about parts of their anatomy. For some of the shame and taboo around what we call our genitalia may be stopping that dialogue happening. So having things there that patients can hold, I can pass over and tell me what it's feeling like, so I can help you improve the experience that you're having. So setting the scene. This was, well, it was in COVID when we were seeing patients, and that's why my picture's on the desk, because I had a mask on. And I'd had a lot of patients saying, what do you look like? I feel a bit inhibited with the mask there. So I've had the picture. Because people need to feel comforting, engaging, that you're looking at them, that you're not looking down at your notes or you're writing, and you're not actually listening to what they're saying. There's a lot of myth around male patients wanting to speak to a male clinician. I would totally disagree with that. I think anyone can be speaking to the clinician, male or female. It's about having empathy and understanding. And I have a lot of men who say to me, I'm glad I'm talking to a woman. Now, being mindful of that is really, really important. And as the day went on and my clinic occurred, various things came into view. And I would encourage you to think about, what do I have in my clinical room to aid this discussion? So you can see that I've got an A&P. I've got it here behind me, and I've got one on my trolley. Now, I've gone to the dizzy heights of a trolley because I've been around a while. But it might be, I started off originally with a drawer. You might only have a drawer in the clinical room, but start to think about, what could I have that I can put in there that can aid the consultation? There's a bag. I was recently in Ireland and I put everything in there. I had it in my luggage, and when I got there and I was going to departments to talk about how to talk about sex and sexual well-being, the amount of stuff that I could get out that could easily be put into a clinical area was quite phenomenal. And it just helps to break the ice, because that's what's needed. We need to get rid of any shame and taboo and just normalise the discussion. Let me move on, and there's a toolbox there as well. And we can think outside the box. So you'll be surprised how much knowledge you've probably got. I talk about vibrators. It may be, there's a pink dilator there that you can see on that top left-hand side. There's a set of 5. I've got one here, and they're really flexible. And the number of people who've said they've been given this bag of hard plastic dilators and they didn't know what to do with them. And I totally agree, that's not giving the best standard of care that you should be able to have in a safe environment where no one will be overheard, that you can actually discuss about how dilators can be used. And it might be about talking about using them with lubricant. These are silicone dilators, so you wouldn't use a silicone lubricant, you'd use a water soluble so it doesn't damage the silicone. But I think if you're curious how things work, what the patient needs, you'll start to gain this knowledge. And there are some rings there as well. They're called O-nuts, and they're to help about deeper penetration. So I think, like everyone, you start to learn things, you'll be curious about it, attend webinars, and you'll get to gain more knowledge, because very often people will say, well, where can I go on a course to learn more? There are some courses for psychosexual therapy, but a lot of the time we're actually having to learn on the hoof, and it might think, oh, I'm not very good at doing this, but you probably have got more knowledge than you think about. Age is no barrier, and I've got that there with the bus stop in Baker Street where these hands were there, and so many people make assumptions about older people not being sexually active, which is completely wrong. And sex toys, the basket was actually at a supermarket, and I noticed that the sex toys were on offer. So you get points, and humour can be brought into your dialogue with patients, or if you're a patient on here, you might find humour helps you to have that discussion with the clinician. So if you get your extra points when you're buying your sex toys or your bacon or your butter like I did, get it out, talk to your partner about it. Say you heard it on a webinar and you were just a bit curious and you wonder if it could help you. Because again, it's all about opening up your senses and being aware of how you can bring a positive change to something that can be quite a devastating diagnosis when you have a cancer diagnosis. Outer course, it's not always about having intercourse, it's about being able to communicate. So you don't need specialist knowledge to be able to talk about that with patients, and how it's important that they talk to you and you follow up those appointments with them about how have things been since the last appointment. And it might be you'll be asking about how's their desire, how's their sexual desire. You might talk about masturbation or self-pleasuring. What word do they use? I often say to guys, you know what, I like the word wank. We always know what we're on about when we talk about it. And they may laugh and it puts them at ease. So you've got to find a language that makes you feel comfortable, that it makes it easier to have the conversation. You might be talking about lifestyle change, that if patients get really tired and they're having ongoing radiotherapy, their intimacy might be having a cuddle in bed and having a nap with their partner, laying on top with just a duvet over them, and kiss and being held. You don't have to know the answers, but you should be able to, and Holly mentioned that earlier on, you don't expect to be experts in sex therapists, but you should be able to have that dialogue. Let me check the time. I know I haven't got a lot of time and I like longer. It's a bit like sex really, isn't it? Have a quickie or a nice long time. Relaxation is important to talk about. Brain's the biggest sex organ. Breathing, kissing. Someone's had treatment around their mouth and their saliva glands have been affected. It may be very difficult to kiss. So be thinking about artificial saliva, or how will they make up for the changes that have happened with their face with some treatments, about being sexually intimate. This is one slide that I really want you to remember, and it's the PLICIT model. And permission to talk about sexual function is what all of you are empowered to be doing. And again, if you're a patient, you have the right to be asking for help and support. It's okay to have thoughts, fantasies, and behaviours. That is normal sexual behaviour. You might have limited information. So again, ask, be curious and find out if, why and when, because it will impact often your disease. It might be you have a stoma. One thing, let me show you. If you're changing a stoma bag or you're teaching patients to do so, you can get really nice covers, you can get sexy underwear. And today is actually National Lingerie Day, which I posted about. I do LinkedIn, Twitter and Instagram. And I've posted about National Lingerie Day because I think these look quite sexy. A stoma bag will fit within it. And you can easily talk to patients about their sexual well-being whilst helping with the stoma bag, for example. Specific suggestions, and it might be about positions. So if someone finds that there's a sex position that is uncomfortable for them with the treatment that they've had, you might suggest different ones in different ways. You may have to do more intensive therapy and you feel like, do you know what, I've reached that point, I'm going to refer on. But you can signpost people to information. And the expanded PLICIT is actually reflecting and seeing how the intervention that you've talked about has had an impact. So that's me. I'm always happy to answer any questions if you're stuck on anything, because I'm just so passionate about what we're all in this for. And thank you.
Thank you so much, Lorraine. That just wonderful, and God, I've learned so much as well. And I'll now be going to check my local supermarket and
Good.
seeing what are the added bonuses and getting my grocery shop. So I'm going to pass over to Lindsay now, and Lindsay's going to run the Q&A session for us. You're on mute, Lindsay.
Of course I'm on mute. So my first question is for Holly. And I guess one of the questions I wanted to ask was in terms of like receiving information as a patient on something like this, when is the best time to receive it? And kind of what format do you think would be most useful? Like, is it a leaflet? Is it like a, you know, a website to go to? Is it, yeah, how is best to deliver this information, do you think?
Yeah, that's a good question, Lindsay. And I think it's not straightforward because I think it's going to be different for every kind of patient. And for someone like me, I'd be really keen to have as much information as possible as early as possible so I can be thinking about things. But for some patients, they might find that really overwhelming. You know, if you're sitting down and talking to someone about their diagnosis and you also bring up their sexual well-being, that might be too much. But equally, you know, I think I stress that we need to be talking about this as soon as possible. So I would encourage I would encourage us to talk about it as soon as we can, but at a time where we don't feel like the patient will be overloaded with information. And again, in terms of what sort of information we give, I think that's going to be really dependent on the patient themselves. I would certainly have liked some written information as well, but absolutely some links to websites and things. One website that is really great is it's actually an online sex shop called Joe Divine, and it's run by a woman called Samantha who has a background in nursing, and all of the toys and things like the dilators and the lubricants, they're all safe for people on treatment. So directing us to places like that where we know we're going to be able to access things that are right for us, that are safe for us, and there's lots of information about that as well. But I think making sure that we have lots of different types of information is going to be best, because particularly younger people, they might prefer more digital things, but older patients who don't have access to computers and stuff, they're going to need leaflets. I hope that answers your question.
It certainly does. Thank you.
Cool.
So my other question is, I guess, Lisa, in your research so far, when do you think is the best time to give patients information? Because obviously in the radiotherapy department, we generally see people when they're coming for radiotherapy. And I almost feel like we need to get a bit of prehabilitation going and try and get them before that stage. How do you think there's a mechanism or a gateway where we can get to patients sooner about things like this?
So we spoke to a group of consultants about, what can you expect from treatment, or, and we talked to people about any kind of skin reactions. We talked to them about various things, and then the consultants were saying, well, we've not got time to talk about sexual health. And it's like, well, you are deciding what is important when you are consenting patients, and you are making that cut for people, and that is not fair. This is just as important to bring up. It's part of informed consent, and if we aren't consenting people about their sexual well-being, their sexual health during and after treatment, then actually we're not doing informed consent. We've got a duty of candor, like we need to be talking about this right from the start. And just thinking about what you were asking to Holly, one of the things that people said to us in the project was, oh, not another leaflet. Like you could get a book with all the leaflets that people are handed at various stages of their treatment, and that's why we really try and focus on this. It's about conversation and about kind of, so that was the purpose of the poster, really, just to say, I am happy to receive these questions. And the thing of the lanyards, like if people are wearing them, it's visible to say, you can, and in fact on the front of the lanyards it says, you can talk to me about sexual well-being. And because we just wanted to, you know, it's about giving people permission, making it open, having the kind of, you know, the presence of the things, the conversation is available to them.
I suppose it's making, as you say, making it available and making it like at every point in the pathway, there's something that is around that can trigger that conversation.
Yeah.
And let people know it's okay.
Yeah. And then, you know, not everybody feels comfortable having these conversations. And so then it's about saying, I am not the best person to have that conversation with, but I know that one of my colleagues would happily talk to you about this, and then introducing the conversation, not saying, right, I'll book you in, and then the patient has to then repeat what the issue is, and then it's embarrassing, and then actually kind of facilitating that introduction so that the conversation flows. It's not these kind of stop and start interactions, because there'll be nothing worse than having a conversation with somebody who actually cannot physically bring themselves to do it, but to pass them on and to facilitate that passing on, I think is really important.
I guess that brings me on to the conversations to sort of where about referring on, really. I mean, where do we refer on? Is there, because there are not, you know, there are not people in every hospital with which you can necessarily refer on to about sexual health. So I suppose it's more that kind of like, are there support groups? Are there, you know, places that we can send people to when we don't have the answers? I
don't think that in a lot of cases people don't need referring on all the time to a sexual therapist or a psychosexual therapist, because sometimes it is just saying, this is a bit crap, what could I possibly do about it? Now, you don't need to have 1,000,001 qualifications to be able to say to somebody, to empathise with somebody and to say, you know, just have a few bits of information. So I think the referring on is about putting people in front of somebody who is prepared to have the conversation, rather than waiting for there to be a funded referral pathway that people can follow.
Yeah, I agree with that, because when I was a clinical nurse specialist in doing erectile dysfunction, I wasn't trained as a sex therapist, but I look back and think I was competent to a degree. I didn't realise that myself. That's why I was saying earlier on about empowering people on here. You will know a lot, you just don't realise that maybe, or feel confident to do so. But you can upskill and train. I mean, professional accountability is really important. And I think whoever's talking about sex with the patient, you always have to be mindful that there may be some underage sex occurring, and you've got to be accountable for that. But generally, there are simple steps. But again, it's just having that person who will make sure that this will be discussed immediately at the very beginning. I actually email patients and say that I work as part of the team, because patients don't know what they don't know. Holly, you would have had no idea before you had your diagnosis what to expect. So I say to patients, at the moment, this may be feeling overwhelming for you, but I want you to know what's in the cupboard there to help you when you need it at any time. And that empowers the patient and puts them in control, then deny them any information. So that's really important.
One last question I want to sneak in from one of our people. It's, how would you broach a person who was more sexually sheltered, lacked awareness, and ensure their comfort? It's probably for Lorraine, I think.
Well, how would you know that they were shy? Because let me tell you, some people that you think may be shy might be having a rip-roaring sex life behind closed doors. So I'll just flag that up, because again, it can be a bit of assumptions. If someone tells you that, you can empathise with them and say, that's really interesting, tell me a little bit more about that. Sarah Quinlan, your lovely Irish accent. I was in Ireland speaking when I was on about my bag. And it was really interesting. And me in the north of England, originally growing up, I never talked about sex. I can't believe I'm doing the job I'm doing now. So there'll be a cultural thing there, but it's acknowledging it and accepting that and empathizing and saying, well, let's see how I can help you with that. It's okay. And holding, if you give a minute when someone says something like that and there's silence, they'll talk more. Why do you feel like that? Is it to do with your upbringing? Would you like to be different? You know, some people actually have a cancer diagnosis. I've got men who say I've got a better sex life now than I had before because they had pre-existing. Or you might wear a wig and choose to wear a wig. That's a very different look to how you were before you had your hair loss. And bring that into some sort of sex play. Why not think about that? Expand things in a different way. So who'd have thought that? Is that person really shy?
Brilliant. Thank you. Well, I think that just about rounds us up, doesn't it, Sarah? Did you want to finish up quickly?
I did. That's great. Thank you so much. Thanks so much, Holly, Lisa, and Lorraine. That's just such a fascinating nearly hour there, and just think everybody will take away a lot from it and probably a lot to reflect on as well. And I think it'll be the sort of thing that we'll think about in a week, 2 weeks time. So and just let everybody know that this is being recorded and will be available to watch back and to share with your colleagues as well. Please also do remember to leave a comment in the chat with your one takeaway from tonight. It really helps us with kind of evaluating and showing the impact of these webinars. I'm just going to share very quickly some headline updates from the charity. So first of all, it's time for Miles for Radiotherapy 2024, which is so exciting. And this year we're off to a really great start. We have AXREM, Leo Cancer Care and Radioderm on board as event supporters. So this is the first year we've been doing the event supporters, and delighted to have the support. And Joe and Naman from the Rad Chat podcast are joining us as media partners too. So participants this year will get a welcome pack, a snazzy multifunctional headwear, and a sponsorship form to get started, and a thank you lanyard from us at the end of the event. As well as the virtual challenge this year, we'll have a Radiotherapy UK team at the London 10K on July the 14th, and on July 21st, we will be inviting you to join us in Yorkshire for Runable's 3-mile and 10-mile trail race day. So we'll be in London and in Yorkshire in July if anybody would like to come and join us in person. So you'll be able to enter from the 1st of May, and we look forward to welcoming you all. Every pound raised and every mile travelled will go to support our Catch Up with Cancer campaign, the UK's longest and loudest campaign about the current cancer treatment crisis. And I just wanted to highlight as well a recent report, because we've so many here from the radiotherapy community. So this is our latest report, written and researched by Dr. Alistair Ray, Equity of Access to Cancer Treatment and Analysis of Travel Times to Radiotherapy Services. And this report received major media attention, including front page coverage in a national newspaper. And really what it does is it just highlights that 7.4 million people in the UK are living more than 45 minutes away from their closest radiotherapy centre. And shockingly, also, when we look at public transport, it's 50.2 million people away, showing that many households without a car are facing real barriers to radiotherapy treatment. We have some really strong recommendations in that report, and would urge you all to go and read it and share it with the rest of the people, with your colleagues and anybody else who will want to know about this. Sarah's going to be putting a link into the chat right now for that. Word of mouth really is our friend about this. We're a small charity, so it really our impact grows whenever people talk about the work we're doing, and our work as well is all focused on having impact, on getting down through the data and crunching it and finding out what's really happening for patients. Another good example of that is obviously our vision document, which we facilitated recently, and that's been one of the most visited web pages that we've had online since February. So I will let everybody enjoy the rest of their evening tonight. Thank you so much for joining us. Again, thank you to our wonderful speakers. It's a really fascinating evening. So Holly, Lisa, Lorraine, thank you so much. And I hope everybody enjoys the rest of their evening.